All right, so it is around 11:05-ish on April 15th, 2021. We're going to go ahead and look at review for your anatomy practical, and then also look at review maybe if we can get time for your modalities practical final. Sorry, you're not doing your practical this year. So this practical is primarily consisting of muscle or myotome testing, right? So it's got most of your myotomes that are on there. It's got some cranial nerve myotomes as well that go along with that, right? So the main idea here is just making sure that you understand what the myotomes are. So these are your practical cards right here, obviously, that we gave you guys for you guys to practice. So they're all in here. But you also have this nice sheet that Dr. Johnson put together for you with all your testings, right? So how is this going to work? This is going to work very similar to the last one we did, where you guys are going to walk into the practical with me, right? Going to pull you. I'm going to probably put a sign up front again so that you can choose when you want to go a little bit. I'll pull you and your partner. You'll come in. You'll draw one scenario card, only one, no more than one. That scenario card, once you draw it, you'll start with your normal introduction. You know, hi, my name is Mr. McKeever. I'm your physical therapist assistant for the day. Today, we're going to test your C1 and C2 muscles. Is that okay that I treat you? You've gotten consent, you've told them what you're doing, and you've introduced yourself, right? Then you're going to perform that test. If the test has a bilateral component, you're going to test bilaterally. In the case of like C1, C2, it doesn't require bilaterally. It doesn't matter if you test bilaterally at the same time or separate times, as long as you test bilaterally. So, for example, when we get down here and we're further down and we're on like C3, right? Or C4 or something to that effect. As long as you test them bilaterally, it's all that matters. Excuse me. I must have not got enough sleep last night. So if we're testing shoulder shrugs, right? It doesn't matter if you say, okay, shrug your shoulders to your ear. Okay, I'm going to push down. Don't let me push you down. And you do it both sides. Or if you say, okay, lift your left shoulder. Don't let me push you down. Lift your right shoulder. Don't let me push you down. Or if you have the biceps, you're like, okay, pull your arms up. Don't let me pull you down. You do both of them at the same time. As long as you can effectively tell what their strength is. Once you've tested both sides, you'll then turn to me and say probably that they're a normal grade of 5. Because most of us, with myself as an exception, most of us should have a 5 out of 5 on most of our tests, right? Even the finger separation one, I mean, I don't have a lot of force there, but I can at least resist moderate force. That's still a 5 out of 5. Then you'll get a question, right? So I might ask you, well, what would an abnormal test look like? Well, an abnormal test would look like maybe where one shoulder raises and the other doesn't. Or you raise the shoulders up, one shoulder breaks and the other one doesn't, right? Or you tell the patient, raise your shoulders, and like, okay. And they don't do it. Or they do it kind of spastically, right? Or when they do it, they get something maybe where they get a little bit of clonus while they're doing it, right? That clonus is where that kind of, you get that beating going on. Those would be abnormal results. That's the extent of the test. As hard as it is, 10 easy points. You should be able to simply get a quick score of 10 out of 10 on that. I mean, it's not far different from your last practical portion. So, and I thought I muted my phone. I evidently didn't. Now it's muted. Sorry about that. So let's kind of go down through them. We're going to talk through them and then I'll perform them. So let's talk about C1, C2, right? So with C1, C2, what's my test for C1, C2?
Cervical flexion.
Yeah, cervical flexion. So, right. So you're going to have me, the first thing you're going to have me do is do it. Right. So you want me to flex forward and back. So you're going to say, okay, Mr. McKeever, bend your head forward. Okay, good. Now, bend your head forward. Where are you going to put your resistance at?
Your forehead?
Forehead. Yep. So you're going to put a little bit of resistance here. And you can say, you know, don't let me push. I usually say, don't let me push you back. That's usually my way when I'm doing it. Don't let me push you down. Don't let me push you out. Whatever it is, try to make it something that they can easily get. So you're gonna put some resistance on my forehead. 5, 4, 3, 2, 1. Good, you're done. Mr. McKeever, great. I graded, you know, Reagan's cervical 1, 2, and they came out as, you know, 5 out of 5. What would be the difference here if you had a test, and this is just, again, a step further than your practical here, but what would be the difference if this instead said test CN1, CN2? What would that mean?
The cranial nerve?
Right. Yeah, don't make a simple mistake like that. Just because I had you know, when I broke my neck way back when, you know, about, so I'm at like 8 years now. It's scary. When I broke my neck like that, and I was seeing a specific physical therapy company in town here, they kept sending reports into my workers' comp claim saying that, you know, well, you know, my workers' comp's like, well, he doesn't need surgery. Obviously, he doesn't need surgery. And so we called them, my PT and I called them, and it turns out that company was reporting it that I had a CN 4, 5, and 6 damage instead of cervical 4, 5, and 6 damage. So my workers' comp company is saying, well, no surgery is going to help cranial nerves. You can't go in and, I mean, you can go in and do surgery on the brain, right? But they're not going to go in and do surgery on cranial nerves. And so as soon as they corrected that, within 2 days, I was in to see a neurospecialist. But I had waited a month and a half, and by that time, I had lost all use of my left arm because they had delayed that. Right? So make sure that when you're documenting, you document specifically if it's cranial or cervical root, right? Just kind of an aside to this test as well. So if that's C1, C2, let's go down to C3, right? So now we're going to keep moving down.
Mr. McKeever?
Yes.
So for C1 and C2, you would have them flex their neck first before doing the test?
Yeah, all the tests, you want to see them do it first. I'm sorry, I should have specified that, right? And that's going to come into play next semester as well when we get into manual muscle testing. Because manual muscle testing, you're going to have them do the item first. Now, ideally, and you don't have to do this for your practical here, but ideally, you're going to want to see them do it against gravity. And in reality, if I have myself flex my head forward, is that against gravity? Or is that with gravity?
That's with gravity?
Yeah, that'd be with gravity, right? Gravity's helping me flex forward. So ideally in the real world, and when we do it next semester, you'll have the patient supine and lift their head up like that so they go against gravity. Doesn't matter for this test here. I'm not getting that far into the weeds with you, right? You know, and if you're like, you tell them to do biceps and they do something like this, I'm not going to yell at you. I may tell you, hey, it's better to have them go against gravity, right? It gets you better set for next semester. But yeah, so you're going to tell them, okay, I'm going to have you go ahead, right? And the best thing to do is I'll teach this to you guys next semester when you have me heavily, is I'm big into giving my patients STDs. No jokes, no laughter. Okay, I got somebody. Okay. What I mean by that is you show them, you tell them, and you have them do it. STD, show, tell, do. You'll hear me say that over and over and over again next semester, right? So you'll say to them, okay, I'm going to have you flex your head forward just like this, right? So you're bending, so I'm showing them, right? So you're bending your head way forward. Do you understand that, Mr. McKeever? I've told them, and then I'm going to have them do it. Because you got to remember, in Las Vegas here, we have a 7th grade average education level, right? And if you say, you know, Mr. McKeever, could you please flex your cervical flexor so that your chin touches your chest? You may get somebody that's like, cervical, what? Right? So you got to show them, okay, I'm going to have you do this. Bend your head way forward, right? Even though when we document, it is 7th grade, believe it or not. We're like, I think we're 48th, I think, in the country. Go Nevada. That way, when you document, though, now you're going to go more anatomical, right? When we talked about pain, you're going to document pain anatomically, right? Well, same idea here. Shows in the driving skills. You are not kidding. Shows in the choices, too, right? So we did C1, C2. Let's do C3. What's C3?
The cervical side bending.
Yeah, side bending or lateral flexion, whichever you choose, right? So again, you're going to come up to me and go, okay, Mr. McKeever, what I'd like you to do for me is take your head. I want you to touch your left ear to your shoulder and then touch your right ear to your shoulder. Now you know I can do it, right? And then you're going to say, okay, touch your left ear to your shoulder, hold it, and don't let me push you back. 5, 4, 3, 2, 1. Good. Let's go right ear to shoulder. 5, 4, 3, 2, 1. Done. Right? 5 out of 5. Congratulations. That actually caused my neck to flare a little bit. That wasn't fun. Now, yes, I heard. Yep.
Do we count like how long we're supposed to hold it?
I tend to, just because it helps the patient understand how long you're doing it for.
Okay.
Right? If you're pushing, okay, don't let me push you up. How long do I have to hold this for? Oh my God. Right?
Okay. Yes.
It just makes it whether you do a 3 or a 5 count doesn't matter. The only reason I do 5 is because guess what? Next semester, when you do manual muscle testing, it's a count of 5.
Okay.
So I've gotten into a habit of that. These are more for testing spinal cord injuries, right?
Yes.
So in spinal cord injuries, we do typically do a 3 count, but even in spinal cord injuries, I've just gotten used to it. Because here's the deal, if they can do a 5 count, they've done a 3 count.
Okay.
That's the way I look at it.
Makes sense.
It also makes sense because, again, you know, once you get out in the field, you have so much going on in your brain that you want to do with patients. It's much easier to kind of bring everything down to the same.
Yep. Okay, thank you.
Yep, no problem. And it also keeps you focused, right? If you're like, okay, so you're not holding it for too long. 5, 4, 3, 2, 1, good. 5, 4, 3, 2, 1, good. You're done. All right, so we did forward, we did side, right? Now we're moving to C4. C4 is what?
The scapular elevation.
Yeah, right? I don't know. But wait a minute. Because I remember for a cranial nerve, we do that too, don't we?
11 cranial.
Accessory.
Yeah, accessory, right? Cranial nerve 11. Good, right? Well, what's the difference there? Hint, there is no difference, right? The major change is with the cranial nerves, you're actually testing if they're lifting their shoulders themselves, testing the upper traps, right? But along with that, when you lift your upper traps, you're going to elevate the scapula, right? What muscle helps elevate the scapula? Do you remember?
The traps.
Traps, and what other ones help?
Rhomboids.
Rhomboids, right? A little bit. Another one?
Levator scapula.
Levator scapula, right? So in reality, the C4 test is more for LS, levator scapula, because that one is truly kind of innervated by a C4, if that makes sense. But you're going to get a group, right? It's not like if I test this, I'm only going to get C4. I'm also going to get accessory nerve. Does that make sense? You can't separate them. Now you can, there are tests to purely separate if you get into spinal cord especially, but that's, again, here, you guys are here. Don't confuse that right now. Just say, okay, lift your shoulders up, right? You're gonna come and put your hands on my shoulders, go, okay, don't let me push you down. 5, 4, 3, 2, 1, good. Done. Easy peasy, lemon squeezy. All right, C5, right? C5 is what?
Shoulder abduction.
Right, so here, right? Right, in the martial arts, we call that the moon rising, right? So that's a little harder to do both sides, right? Because you got to go kind of winged way out in order to resist them. So it's a little easier to do one side at a time for you. So just think of that when you're doing it, right? So you're going to say, okay, Mr. McKeever, I'm going to have you take your arm. How should the thumb be?
Facing like out.
Nope. That makes it harder.
Oh, so down.
Nope, other way.
In.
You're always going to do a thumbs up.
Oh, that's what I meant. Sorry.
Yeah, right. So if I have my thumb pointed this way or pointed down, when I come up, you can feel it yourself. Do that yourself once. You'll feel that that scapula starts impacting that shoulder. You can't go as high. You see how I can't get any higher than right there with this, right? You may have a little bit more flexibility. Shush, be quiet there, right? But for most patients, that scapula is going to get locked. Whereas if I do this, Now I have that humerus externally rotated. It's a little easier to come up like this, right? That's what we call, you hear sometimes I'm saying empty can position, that's thumbs down. Whereas open can position, they call thumbs up, because if you're holding an open can, you don't want to spill it. Right, so you have them point their thumbs up. All right, go ahead and bring your arm out to the side. Right, okay, now don't let me push you down. 5, 4, 3, 2, 1. Good, let's do the other side. Does it matter what side you start with? No. I tend to always go right to left just because there's no logical reason why I do right to left. In the real world, you may want to start with the good side and then go to the bad side, but it doesn't really matter. Not for the test.
Mr. McKeever,
Yes.
how do you support this one again?
Okay, so how would I support this? It's a couple of different ways I can support it. Typically, I'm going to support on the contralateral side. Right? The one thing you're going to notice is how's a person best going to cheat with this one? What are they going to do?
Gonna compensate?
Yeah, they're going to cheat and they're going to lean. Okay, I'm moving my shoulder, right? They really didn't move their shoulder. They just moved their body. Right? So if I put my hand over here, I can keep them from doing it. You can also put your hand here on this shoulder and stabilize. There's not a real wrong way to stabilize for cervical nerve root testing. As long as what I see is one hand is stabilized in the patient, the other is testing. What's the goal of this hand here, the stabilized hand? Keep the patient from cheating, and if your patient falls over, that you can grab them. That's really what the stabilized goal is. It's not necessarily that you're putting extra resistance somewhere else. It's safety, right? It's to teach you that baby step of keeping your hands on the patient at all times. Baby steps, Bob, baby steps. Does that make sense, though? So either contralateral or on the same shoulder, kind of going up. And again, if I put my hand on this shoulder, it does keep me from kind of leaning as well. The goal is to keep me from side bending. All right. Now we got C6. What's C6?
Elbow flexion and wrist extension.
Good, right? So it's the combined motion like this, right? So that's a ring, ring, ring on a motorcycle, right? Or the lawnmower, I guess some of the lawnmowers have that too nowadays. Because, dads got to feel like they're riding a motorcycle while they're out mowing the lawn. So do you want to do them together? Probably not. Right? And this would be one of the places where you may lose a point or two. Because I've had people come in and they just do elbow flexion. And I kind of sit there and I give them a few seconds before I say anything. Right? And I'll say, is there anything else you want to test? And they'll say, nope, I'm good. Are you sure there's nothing else you want to test? And the good people will go, oh, wrist extension. And then some of the people will still say, nope, I'm good. And then I'm going to have one of those sheets with the tests that I have on my desk. And I'll say, can you please consult the sheet, see what you missed? At that point, you lose 1 point. That's it. You'll consult the sheet. You'll do oh, yeah, I forgot about wrist extension, Mr. McKeever. Okay, let me do that real quick. You lost a point, but at least you didn't lose the whole test, right? So for biceps, right? So you're going to have them say, okay, so what I'm going to have you do, Mr. McKeever, is show me your guns. Bend your elbow up like you're trying to touch your chest or something like that. Okay, good. And hold it. Don't let me push you down. 5, 4, 3, 2, 1, right? Now I will have a fixed chair in the room with me. Yep, no problem, Stephanie. I will have a fixed chair, meaning the arms will have fixed arms, because that one of the concerns is when you're on a rolly chair, you kind of move all over the place, right? So that arm will have an armrest where you can put their arm down on that armrest and say, okay, now I'm going to have you lift your hand up to the sky like that. Okay, don't let me push it down. 5, 4, 3, 2, 1. The key thing is that arm should be on something supportive. That could be your leg, right? You saw him test it one on my leg when I was doing it, right? It doesn't matter where you put it as long as it's supportive. Could be a desk. But like I said, I'll have one of those armchairs in there where you can kind of rest down and they can do that. And then on the next one, you can do flexion as well. Makes it a little easier on you. When I do this, I tend to test flexion, flexion, extension, extension, because it's easier on the patient to have them do one activity at a time, right? So if they know they're doing this on this side, then they know they're going to do this on this side. Then I'll tell them how to do this, then I'll do this. I don't ever test them simultaneously. That's just way too complex for most patients. So good. Okay, so let's see here. I was getting there. Where do you stabilize for elbow flexion? For elbow flexion, I typically stabilize at the shoulder. And a lot of times when I stabilize at the shoulder, I kind of trail my fingers down. Why do you think I'm going to trail my fingers down like this a little bit?
To feel the muscles contract.
Yeah, exactly. You know, my pinky's not stabilizing a whole heck of a lot of anything, but it's got some sensation in it that I can feel at least when that muscle kind of squeezes, right? If they're at a 1 or a 0, I can tell if they're at a 1 or a 0. And then for wrist, right, you're going to stabilize somewhere on the forearm and then push up, push down up at cords here, right? Don't push out on the fingertips. That's just mean. Right, remember, when you do that, you've lengthened that lever arm. Do you remember that from back in physics and also in intro to kinese? If you lengthen the lever arm, it makes it harder, right? Like when you're doing that shoulder abduction. If you test me and put my resistance all the way out on the wrist, a lot of patients are going to break, right? It's better to put it closer or proximal to the elbow. So just try to be nice to your patients is what I'm saying. Don't totally torture them. Now, you know, if you want to, you know, if Brooke's your patient, you want to see how much her guns are firing that day, fine, and make her work hard. But I'm not going to dock you if you go too far out the arm, but it is kind of nice to be nice to your patient. So 6, flexion, extension, done.
And then for the verbiage, we're for all the tests, we're going to just say we're going to test your muscles.
Yeah, test your muscles. That's all you're testing. Right
Okay.
now, in reality, you're testing nerves. They just don't know that. It's easier to explain to a patient, I'm going to test your strength, right? They understand strength. They don't understand, I'm going to test your cervical nerve roots today. Wait, you're going to do what to my spine? It's just a little easier to tell them you're going to test strength. All right, so we did C6. What's C7? Yes, you're going to test
extension.
Good. Elbow extension, and what's the other one?
Wrist flexion.
Wrist flexion.
Yep, wrist flexion. Yeah, so I had 2 questions. So Bianca asked to double check, do we test both sides? Yeah, if the ability to test both sides, you're going to test both sides because you got to have something to compare to. Right? If I just test this side and I'm weak, it doesn't tell me anything. I got to check the other side to see if it is, right? Because what if I'm a 4 on this side and a 4 on this side? That could be normal for me. I may just be generally weak. Right? And yes, you're testing the motor component of the cranial or the cervical nerves, right? Just like when we get to the cranial nerves, you're testing the motor component of the cranial nerves, right? So that's where you're testing that down firing nerve, right? The brain is sending the signal down saying move, right? So C7 is elbow extension and wrist. What was it? Again, I got confused. Wrist.
Flexion.
Flexion, good. Right? So opposite of this one, right? There are a couple different ways you can test that. Again, if you test elbow extension where you have them push down like this, I'm not going to dock you. But in the real world, ideally, we want to kind of test it out like this because we want to add what? What are we adding if I test like this? Gravity. Right? Here, if I go down, gravity's helping me go down. If I do the robot, I've got to go against gravity. So elbow extension, right? You're going to tell me to do that. Now, the one key thing, and I'm not going to, again, dock you on this test for it, but next semester I will. The only thing that's different about this one than a lot of the others is you don't want to test this in full lockout. Because if you test it in full lockout, what's locked in place that's actually holding me into extension?
Just the elbow itself is locked in.
Yeah, that olecranon's locked in that olecranon fossa, and that literally is a key and lock, right? Once it's in there, it's kind of like Prego, right? It's in there. It's like the spaghetti sauce. Prego, it's in there. And it's locked, right? So we want to unlock that slightly so that we're actually testing muscle, not bone integrity. Right? So we're going to tell them, okay, go out. Okay, relax a little bit. Now don't let me push you down. Good. Then we're going to put the wrist on the armrest again. Okay, now I'm going to have you bend your wrist up. All right, hold it there. Don't let me push you down. Strength.
Mr. McKeever?
Yep.
For the locking in, is that same, like, does that go for, like, knee extension?
Yep.
Okay. Because I did these all on my grandma, and she was, I would say she graded a 5 for her upper body and then a 4 for her hips, especially because they gave a little bit.
Yep.
So, and I told her, like, without even knowing, I was just like, make sure you don't lock in because I want to test the muscle, not like, you know, your strength of you locking in.
Yeah, so we'll learn with the knee, right? When we extend the knee out, we'll eventually get what's called the screw home mechanism. And what happens is, so here's my tibia, here's my femur, right? So I've got that little, the tibial condyle kind of moving in that femoral groove in between them, right? And I've got the kneecap floating out here. What'll happen is when you fully extend, there's a little bit of medial rotation that locks that knee in place. And when you're there, it's really hard to break it, right? But if I come out of that slightly and get just a little bit flexed, it's easier to break. It's not as much bone on bone. So good question. With the elbow extension, where am I going to stabilize?
Under your arm, kind of?
To stabilize under the arm, right? To stabilize the shoulder. Any of those are valid. I sometimes do hold the arm. It's up to you. Again, if the patient doesn't have shoulder, you may have to hold the arm. Right? This is going to be one where in the real field, you may have to modify the way you hold stuff, right? But even if you're here and stabilizing, that's okay. As long as you're keeping the patient from doing one of these, right? Look, I extended my elbow. No, you didn't. Right? You want that muscle extending. And then for, obviously, wrist flexion, you're just going to stabilize kind of in the forearm, right? And again, when I do my forearm stabilization, I come kind of across right here because that way, again, I can feel the muscles moving. It helps me a little bit. Doesn't really matter for hand placement right now, but it just is one of those where if I can get a feel on the muscles while I'm doing it, I'm going to try to. So we did C7. Oh, no, now we got C8. What was C8 again?
The finger flexion and the thumb extension.
Good, right? Finger flexion, thumb extension, like it says here, right? So finger flexion, there are a couple different ways you can do this. You can have them supported on the armrest, right? And have them bend their fingers up, and then you can push down. Or the other thing you just have them do is squeeze your hands. Right? So you say, okay, Mr. McKeever, squeeze my fingers really hard. 5, 4, 3. You can feel if somebody's a 5 out of 5 when they squeeze your hands, right? We've all had your little baby brother grab a hold of your fingers and they're like, ee, right? Or grandma hold your hand and you're like, grandma, you got no strength in that hand. But we've all had somebody come up and shake our hand and just about destroy our hand when they shake our hands, right? Because they think they're cool and they're going to assert dominance on us. So either here, bending the fingers up, don't let me push you down, or squeeze my hands, right? Because that's finger flexion as well. Either of those is acceptable. And the only reason I say that is Dr. Johnson showed the early group one way and the late group the other way. So I want to make sure either of those is acceptable. I was like, we're not going to say anything. Right? So either of those is acceptable. So either here, right, or squeeze. Because again, with your fingers, there's not a lot of movements. And then we get thumb extension, right? And so again, stabilize here, put your thumb back, don't let me push you down. Be very careful doing that with patients though, because that tendon there can get irritated really easily. And it can cause somebody, does anyone know what that condition's called when that gets inflamed? Did you talk about that in patho yet? Everyone, Diana's staring at me blankly, so I'm assuming not.
I feel like I have it on the tip of my tongue, but I can't remember.
Decorvain.
It's a lot of information, so I'm not sure.
That's okay. Decorvains is what they call that. right? A lot of people, you know, especially those of us that spend a lot of time gaming, right? Look at the position my thumb's in when I'm gaming. It is not the most, and if I take these off, I have stick extenders. If I take my extender off, I'm really not in a real optimal position. So I can really inflame these muscles really easily. So decorvains is a common problem with the thumb. And a lot of patients will complain, right? So some of you, take your thumb, tuck it into your fist like this, and close your fist around it. Do you get any pain doing that? Okay, good. So none of you really have symptoms for it, right? I do it on, I do it on this hand, obviously, nothing. I do it on my right hand, I start feeling pain going down here. And then the other thing you can do to really kind of flare it up is once you have your finger like this, kind of owner deviate your hand. That really kind of flares it up a little bit, and now my thumb's numb.
Can you show me the first one for finger flexion again?
Sure.
It was kind of blocking. Sorry.
So
Come closer.
Okay. Here, how about this? I'll come up here.
That's perfect. Thank you.
The finger flexion, you have them bend their fingers up like this, right? So they're flexing at what joint here?
Metacarpal one, I think.
Yeah, MCT. Metacarpal phalangeal. Good. Right? You're gonna come out here, it's best if you lay your palm across the whole fingers because way out here is hard. Right? Don't let me push you down. Good. Or you can have them come up and say, okay, squeeze my fingers really hard. Right? And you can feel if they've got a 5 out of 5, right? Because somebody will come up and be like, probably a 4. Either of those is valid for that one. So then we got the thumb one, right? Test for back in my day, testing Fonzie out. Probably none of you know who Fonzie is anymore. All right, and then T1 is the always fun one. What's T1?
The finger abduction?
Yeah, right? And here, this is the one, whatever reason, everyone wants this one because it's so easy. Right? So you're going to have them put their hand either down, or you can even test it in this position where they're kind of resting their elbow down. Whatever works for you. Okay, hold your fingers apart. Don't let me squeeze them together. And again, you're not going to come here and go, because, right, there's not a lot of muscle between them. Does anyone know what muscles do this?
Is it the extensors?
Nope, the extensors do this.
So the flexors?
Nope, they do this. The muscles are between the bones. So between is what's the word for between? Inter. Good. And
Interphalangeal joints.
Well, not even phalangeal. Don't go there. Between the bone.
Oh.
What's the word for bone?
Oste.
Osse. Good, right? So these are your interosseous muscles. Right? And we'll talk about that more next semester, but you have your interosseous muscles that do that, and then there's another set of muscles in here that look like little feathers called lumbricals. And your lumbricals allow you to do what's called tabletop, where you're kind of like this. They both work helping doing this. They're all the muscles, they're in here where they're called intrinsic hand muscles because they're inside the hand, right? All of your muscles that move the hand and the wrist for the most part are extrinsic because they're out in the elbow. Right? But these muscles are actually inside your hand itself. They're intrinsic muscles, right? And you can get, I mean, just doing opening and closing for a little while, it doesn't take long until those finger muscles get fatigued, right? Just sit there and do it for like 2 minutes and see how quickly your hand kind of cramps up because you're not used to doing that. I'm doing it on my left hand purposely so I can feel it cramp up. Does that make sense for the upper extremities? And again, with that one, you don't have to stabilize. There's not much to stabilize there, right? You could hold the wrist if you want. You don't have to stabilize for that one. Right? So we got here, side, up, right? Here, 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 squeeze, squeeze, thumbs up, open, open. There is a dance for that. I'm just not going to do it. If you really want to Google that, there are plenty of people that do YouTube dances for that. All right. Are we okay on the upper extremities?
Yes.
Ça va bien. Good. All right. Let's move now down. So we're going to move down to the lower extremities. Let me see if I can tilt this a little bit, just to save me a little bit of work when we get here. Nope. Do not on this one. You won't lose any points. Start dancing to remember it. I don't care. And honestly, the patients will laugh, so I don't think patients would care either. All right, so we're going to start with L1. L1, I think, is the easiest one. What is L1?
Hip flexion.
Hip flexion, right? So you're going to say, okay, Mr. McKeever, so what I'm going to have you do is I'm going to have you lift your leg up like this. I'm going to push you down. Don't let me push you down. Lift it up. 5, 4, 3, 2, 1. Good. Where am I going to stabilize for this one?
The lower back.
Lower back, ideally, right? Or just keep them from cheating like this, right? I was thinking about this after I did it. I tend to stabilize in the shoulder for this because I can control their trunk even by holding onto their shoulder, but that's just the way I've always done it. There's not a real wrong way here. You could hold onto their lower back as long as you keep them from, because they're going to cheat. They're going to do one of these. Right? They're going to kind of flop back into their chair. So the best idea is if you can get a chair like I'm going to have in the room, right, which has a nice solid back, have them scooch all the way back against that back. Now they can't cheat. Now it's only hip flexion, right? And we're going to do this a lot with patients, right? This is nothing more than marching, right? So when you're marching, you're testing L1. So we got L1. That means if the next test is probably going to be, gee, I wonder, L2,
Same.
right? So L2 is hip flexion again, right? Good. And if you look, the chart shows that. So if you draw L2, you're just doing hip flexion. Don't freak out, right? It looks like there are more than there are, right? So we got L3 and L4, right? L3 is what technically? If you go down here, L3 is knee extension. So how are you going to test that? I stabilize the shoulder. Yeah. Again, it doesn't. So whether you can stabilize, the only reason I say stabilize the low back would be hard is if I'm sitting in a chair like this. It's really hard to stabilize me at my low back, right? When I'm sitting up on the edge of a mat, really easy to, right? But when I'm in a chair like this, unless you're going to stick your arm behind me, which could be weird, right? I tend to stabilize just up here and the main goal of it is, again, what is the reason for stabilization? Keep them from cheating and keep them safe. It's all the reason we do it. So if they, if all of a sudden they start, you tell them to lift their leg up like this, and all of a sudden they start going, oh, you can keep them from falling over. And when I thought about it, Dr. Johnson and I talked about this after the lab, I tend to stabilize in the same side I'm usually testing on. So when I'm testing hip flexion, I usually put my hand on that right side and I test the right side. And then I put my hand on the left side and I test the left side. Yeah, I don't have a rhyme or reason for that. I just do it. Knee extension, right? So I'm going to come out here. I'm going to tell the patient to do what?
Extend the knee.
Yeah, right? I just tell them kick up, right? Like you're a rocket. Kick up like you're a rocket. Good, good. Kick up, right? And then again, just like we talked about, you're going to have them extend that knee up, come off just a little so that they're not in full locking. You're going to push down. So don't let me bend your knee or don't let me push you to the ground. 5, 4, 3. I can't really demonstrate this. This is really hard. I don't have anything to extend, right? Hold on a second. I actually do. Now that I think about it. I have a handy dandy little extendable back scratcher that works. So right, I'm going to extend out. I'm going to push down out here, right? So I'm going to stabilize here at the knee, kick up, push down. 5, 4, 3, 2, 1. Good. Kick up the other leg, Mr. McKeever. Same thing. I had to leave my socks off today, so I kind of feel naked because we have to talk about the toe then. And again, and Ann asked, could I stabilize this one at the shoulder? Sure, I could. Right? But I tend to stabilize this one kind of across the thigh is where I stabilize it. So that was L3, right? L3 primarily only does knee extension. Right? You see up here, L3 is knee extension. L4 is where we start getting into those mixed ones. So here's the deal about L4. L4, if you look at it, does knee extension, ankle inversion, ankle dorsiflexion, hip extension. So the first thing I know that Brooke is going to ask me is, do I have to do all of them?
Yes, I'm already confused.
That's okay. What I'm looking for is 2.
For L4?
Yeah, if there's one where they've got 3 or more, I'm just looking for you to do 2 of them.
Okay, and then L3 is just knee extension.
Just knee extension.
Okay, so on this sheet here, when it says L3 and L4, so L3 knee extension, L4 knee extension, and if I chose ankle inversion.
There you go.
Okay, but they're going to be separate
Cards.
Okay.
Yeah, right, because L3, so this is, again, remember, what you're testing here is patients that have spinal cord injuries, right? So we need to break each level down as we go down. The thing is, L3's primary job is knee extension, right? And when you think about it, what muscles do knee extension?
Your quads?
The quads, right? Yeah, you have 4 of them, the quads, right? But if you look, L3 and L4 do knee extension. So L3 maybe is a little bit more involved in rectus, right? Femoris. Whereas L4 is a little bit more involved in what's the other group part of your quads?
The vastus.
The vastus group, yeah. Right? So that's why that's separate like that. Does that make sense? Because L3 is a little bit more involved in rectus femoris, whereas L4 is a little bit more involved in your quad, your actual rectus group.
Okay.
Does that make sense? Does that help answer a little bit of it? So you draw the L4 card, you're like, okay, well, I can do knee extension, and then I have a whole slew of things, right? I can go knee extension and ankle inversion, knee extension and ankle dorsiflexion, knee extension, hip extension. I could do both my ankle motions, right? Ankle inversion and dorsiflexion, 2. That's all I'm looking for. When you get down here to these ones that have like 4 or 5, like the next one has 4 again, right? L5 has 4 of them. Pick 2 of them. Right? And if you look, when we go down to L5, look at what L5 has. L5 has ankle dorsiflexion, but L4 has ankle dorsiflexion. Oh my God, Mr. McKeever, I'm getting confused. Okay, do them both. So, right, all you gotta do is pick 2. So L4, right? Knee extension, right? Ankle inversion is doing which way? I know my feet are ugly.
In towards like toe in.
Yeah, toe in, right? Good. All right, and you're gonna push them out. Remember, whatever direction you're testing, you're pushing the opposite. So you're pushing me into ankle eversion. Make sense? So put it in. Again, when I do this, I tend to put their leg up on my leg just because that way I can control their leg. You could have them long sitting on the table where their legs are straight. That would work too, right? But then you can't test knee extension at that point. So you have to go with both the ankle motions.
Do we take the shoes off and socks for this one?
Well, at least shoes.
Okay.
Right? Because again, if you have the shoes on, can you really feel the muscles firing?
Not really.
Right. Yeah. So I try to get as much out of the way as possible. You could take the sock off. I'm not going to yell at you, but some people have nasty feet like I have. So I don't know if you really want to take their sock off. I mean, the only one you really have to do that for is great toe, and even great toe you can get away with not actually taking the sock off. You're going to find out really quick, Mr. McKeever does not like feet at all. I hate feet. It's one part of the anatomy, like, ugh. My very first patient I saw was gangrene of the foot, and the toe actually fell off while I was treating it. So, yeah. So ankle inversion, ankle dorsiflexion. Yeah, I know, right? Ankle dorsiflexion. Pull your toes up to the sky. right? 5, 4, 3, 2. You're pushing them into plantar flexion. And then remember, hip extension is probably the most difficult one because how do I do hip extension? It's really difficult, right? Ideally, you're going to do them in prone. But I can do it just sitting here, right? I can have them bring their leg up. All right, I'm going to put my hand down here underneath the knee. All right, push down into my hand. Don't let me push you up, right? I'm pushing down against resistance. You're pushing up or pulling up. That's valid. I could stand up at the table and say, okay, right? Extend the leg back. Now don't let me push you down. It's another way to do extension. Or you can have me prone. Any of those is valid. I will say, when I've seen people do this activity, you get it. Yeah, exactly. You'll get exactly 10 extra credit points. Oh, wait, no, you won't. I mean, if you do all 4, it's good for your brain. I'll say that. So it's extra credit for your brain. I will say that most of the time that people have drawn L4, I think I can probably count on 0 hands how many times somebody's done hip extension. Most of the time, you know, what it is people do L3 is knee extension, and then L4, the inversion dorsiflexion of the ankle. Right? So
easier now that you gave us the other examples, because the prone one is, I don't know, I feel like it's just kind of difficult.
It is.
And for the patient too, because I don't know.
Yeah. I mean, you could even do sideline technically, right? Except sideline is removing gravity. Again, even this one, when I push down is adding gravity. But again, like Dr. Johnson and I said, this is a quick, dirty screening. We're not, you know, we're not really testing each muscle individually, right? This is the spinal cord sending the signal to the leg, right? And so if I come out here and they're strong and they can push me all the way back down to the mat, that nerve is fine, right? Or they start pushing it really strong and I'm able to break them a little bit. The nerve for the most part is fine. The muscle may be weak, right? Like your grandma, you said, right? And her legs broke a little bit. She's probably got fine nerves. It's just muscles may be a little bit weak.
Yeah.
It's almost like we get older, we kind of start sucking. So then we go to L5. L5's got another list of them, right? Dorsiflexion, hip extension, great toe extension, ankle inversion, eversion. I'll say most of the time with this one, most of the students do dorsiflexion eversion. And that's kind of when I was first learning these, I just remembered that L4 was inversion dorsiflexion, L5 is eversion dorsiflexion. It helped me remember them. So again, dorsiflexion we did, right? Full toes to the sky. We did hip extension. Great toe extensions, kind of the heart. Let me see if I get my foot up there, right? Great toe extension. You have your foot up like this, tell them to lift their toe to the sky. You're going to push down on the toe. Again, there is not a lot of resistance in your big toe. I'm just saying. The only thing that probably has less resistance is your baby toe, right? So push down on the great toe, or right here, turn your foot out. Don't let me push your foot in. Resist. I almost have no eversion. And then S1 is eversion and plantar flexion, right? So turning the foot out. And then what do we do for plantar flexion again?
Tippy toes?
Yeah, right? Have them grab a hold of the chair, come up on your tippy toes, right? So I'm going to come, or I can come out here, right? Up on your tippy toes and down, right? Now, if I was testing them each side, I could just have them say, okay, raise your left leg up, come up on your tippy toes. Raise your right leg up, come up on your tippy toes. You don't have to test them individually, but you could. I'm going to be 100% honest. I thought about this after Dr. Johnson taught it. I don't do tippy toes in the clinic. I have the patient here and I have them push down on the gas pedal and I push up. So, I mean, even that would be a valid test. And then if you look, when we get down to S2, it's plantar flexion and knee flexion. Well, wait a minute. right? Where's knee flexion? Oh, we haven't had knee flexion before, Mr. McKeever. Right now we've got knee flexion. We're going back up the thigh. So we're getting into those hamstrings, right? Why do you think we're not testing S3, S4, S5?
With the plantar flexion, are you kind of testing some of the S? Or maybe not? No,
Not
never
really.
mind.
I think with
No.
the hip extension, you're testing them.
Maybe a little. Okay, yep, good. Right, hip extension would test a little bit of S3. There's kind of a more important reason, because we'll talk about testing S3, S4, S5 in when we get to spinal cord. Those are the muscles that control things like your external anal sphincter. And we'll find out about all kinds of fun tests for that then. And also testing your pelvic floor.
So for S1 and S2, are we doing both?
Are they both on here? Or maybe not.
For S1 and S2, there's 2 of them, yeah.
Yeah, so you're just gonna test, yeah, again, you're just gonna do whichever one you draw. So if you draw S1,
Okay.
you know, draw S1, you'll do, you know, ankle eversion, plantar flexion. Draw S2, plantar flexion, knee flexion. Again, knee flexion you can do in prone. You could also do it here, right? Where I'll have them say, okay, bend your knee back. Don't let me pull you out. That's a valid one. You could have them stand up at their chair, kick your butt. Don't let me push you down. Any of those would be valid. Does that make sense for the legs?
Yes, I'm just confused when I look at this paper, but I know looking at this sheet, it'll be better.
Yeah. So with this, again, if I am, here's the deal. If I'm looking at this for testing, I'm ignoring up here. I'm just going to go down here. Because to me, this chart makes more sense to me. Right? Because I go, oh, look, L1, hip flexion. L2, hip flexion. L3, knee extension. L4, I can pick any of these as long as I pick 2 of them. I tend to focus on this one for you guys. We'll talk more about this stuff next semester when we get into grading medial muscles. Don't get hyper caught up in the thing, right? The best idea for you, that's why I talk about show, tell, do, because if you do it, it triggers in your brain what you have to do, right? So show them, okay, you're going to extend your knee up like this. Okay, good. Let's do that. Don't let me push you down. Now, what happens? Let's say you come in and you draw S1. And instead you do S2. If you correct yourself, so if you go ahead and just correct yourself, I'm not going to take any points away from you. I'm going to give you 1 cue. So I'll say, are you sure you tested the right muscles? That's a signal for you to do what? Think about it. Right? If I say, are you sure you tested the right muscles? You probably didn't. So think about it real quick. Oh, you know what? You're right, Mr. McKeever. I tested S2. Let me test S1. You fixed it. I'm not going to take any points. If I have to say, can you please look at the sheet on my desk? And I'm going to keep that face down until I say that. You're not going to be able to go in and go, look at it when you come in. Right? But if I say, can you take a peek at my desk really quick, the sheet on my desk, just to make sure you're testing the right muscles, then you're going to lose 1 point. That's it. 1 point for cueing. I mean, as long as you do most of your stuff, you introduce yourself, get consent, tell them what you're doing, and you demonstrate technical skill, you should get 9 out of 10 at a minimum. The only other thing we'll talk about is the grading. For the most part, all of your patients are going to be 5 out of 5s. Right? It's able to complete resistance with, or able to complete the motion with maximal resistance. We will get much more into the weeds next semester into these here. I'm not going to specifically ask you what a grade 1 muscle test is. That's next semester. Dr. Johnson may ask you on your written test that, but I'm not so much looking forward to that. I'm more looking, if you have a 5 out of 5, I'll say, okay, what would look like an abnormal test? And can you describe what it would look like? Oh, again, one side lifts, the other side doesn't move. One side's stronger than the other. That would be an abnormal test. So don't totally freak out about that. Does that make you guys feel a little bit more at ease?
Yes.
Yes.
Okay, good. Are there any questions?
Not at the moment.
Not at the moment. Okay. Well, again, remember, if for whatever reason you get questions, you still have me tomorrow, Monday, Tuesday, right? You still have a couple of days, and over the weekend. You guys can reach out to me over the weekend. I do respond, believe it or not. I don't have a life. So then, obviously Wednesday we'll do the testing and we'll get it done, knock it out. That's it. It's going to be really easy. You saw how you guys thought the last one was going to take, 20 minutes. Each session took like 5 minutes. Boom, bang, boom, out, done. So it is about 12:03. I don't want to start getting into E-STEM with the fact that I do have some of you guys traveling, and it's, that's totally changing subjects, and I don't want to fry your brain today. Are there any questions on this type stuff for your anatomy, even if it's not on the muscle testing and stuff like that?
I did have one question for the referred pain.
Yep.
Dr. Johnson had mentioned there was a sheet, so we should memorize that or just know like the definition of referred pain.
I would know. So here's the deal. If I'm a betting person, I would definitely know the definition, right? What is referred pain?
Just you feel pain. I don't know like the scientific term, but I guess you feel pain in a given spot where the pain actually isn't like occurring.
Yeah, so you feel pain in a spot distal to wherever the pain actually is occurring. Yeah. Or in a different spot, right? So if I'm having a heart attack, right? What's some of the signs of a heart attack?
Your left arm. And
yeah, my left arm kind of hurts, and then my left jaw.
Yeah.
Right? That's a referred pain pattern.
Okay.
Right? That would be what you would want to know if he's asked, well, what's the referred pain pattern of the heart? That would be what you want to know. But for referred pain, it's just pain somewhere else that's not where the actual pain actually is.
Okay.
We're going to talk about a little, or you may have talked a little bit about this with Dr. O'Neill in the modalities about radiating pain. Mm-hmm. Well, in reality, referred pain is not that much different from radiating pain. Right? So if I have sciatica, my radiating pain is going to go down the backside of my leg, right?
But that makes sense because it runs. So
well, and so that confuses you. But let's think about it. Why do you? So either referred pain or radiating pain. Why do you think it radiates somewhere else?
Just because of the nerves.
Yeah, that's it. And what it usually is we didn't pay enough attention when the pain was wherever it should have been.
Okay.
Like so, when you have a heart attack, sometimes you don't get a lot of sensation in your heart. Mm-hmm. So you probably had, I just got some heartburn. Right? Literally, you're thinking it's more of the stomach than anything.
Yeah.
And then the heart's starting to scream at you saying, hey, buddy, I've got a problem. So it starts referring that pain to other places to warn you, imminent danger.
Okay.
Right? Same idea with the sciatica, right? We walk around all the time, man, my back's sore. Whatever. Mm-hmm. And then the longer you go, the more it kind of moves down because you start ignoring it here. And the body's like, I've got to warn you somehow. That's really what it is. The body's got to warn you, and it moves it away so that it can tell you something's wrong here. Pay attention.
Okay. Out of curiosity, is when someone's like passing a kidney stone, is referred pain in like the lateral side of the back, or is that exactly where it should be because the kidneys do lie?
Well, so it depends. If you ask me, because I've passed a kidney stone before, there's referred pain pretty much anywhere in your lower abdomen.
Yeah. Okay.
That like they joke and say that kidney stones are like having birth for men, and I will openly admit that was probably, and you know, I've had my neck broken. I've had all kinds of other things go wrong with me. Broke my neck twice, actually. Messed up my knee. Kidney stone was the worst pain I've ever been in.
Yeah. I have some, well, my mom, she actually was going through some pain, and like just from going through anatomy, she was like explaining to me, and this was like the first time she ever passed one. And she was like, oh my gosh, like it's just in my back. And I'm like, okay, mom, I was like, I think you should go to the hospital, because if it was just like a stomach ache, you know, it wouldn't be in your bag. And
No.
she was, no, it's a stomach ache. I was like, oh my gosh, she ended up going to the hospital.
And then they're like, hey, you're passing a kidney stone. Good luck. You're going to pee blood soon. Yeah, that was not a fun time. Even for ladies, it's not fun passing a kidney stone. It's painful, right? Because you got to think about it. The kidney stone is calcium carbonate. There we go. I can speak today, which is basically a salt crystal.
Yeah.
And salt crystals are sharp. And your ureter is soft.
Yeah.
So as it's moving down through that, it's digging and jagging the whole way.
Yeah. Just grating it.
Yep. So referred pain is just pain that you feel elsewhere other than the area that it actually occurs in. That's all it is.
Okay. Thank you.
Yep. And then, yeah, just kind of look at the thing. I mean, if I'm a betting person, you know, there's referred pain for gallbladder, because he talked about gallbladder, right? There's referred pain for heart, pretty important.
Isn't the referred pain for the gallbladder in the arm as well?
Yeah.
Okay.
So that could be a mistake, right? We could think they're having a heart attack, and really it's gallstones.
Yeah.
That's why in testings, right? So that, you know, we put them on an ECG and their heart rhythm is completely normal, right? We do a echo, heart's normal. The next thing we got to be thinking about is, where else can that referred pain be coming from? And it's probably gallstones. You know, my dad had that. My dad was a heavy machine worker, and he thought he was having a heart attack on one of those giant excavators. Rushed him to the hospital. He spent like 5 hours checking all of his heart out. His heart was fine. Now, you gotta understand, my dad was like 400 pounds, so big guy expecting a heart attack, right? And they're like, oh no, your gallbladder is basically solid at this point. So they had to pull his gallbladder out. Pull the gallbladder out, gone. Symptoms gone.
Okay.
Now he had to watch what he was going to eat from then on, but he didn't listen to them. But that was my dad. Any other questions you guys can think of? Everyone else okay? All right. Like I said, I think probably what I'll do. So when is your modalities test? Do you know? Is it next week too? 4/29. Okay, so we have a little bit. So maybe how about I'll set up another one next week where we just go over modalities like this. Would that help? Because that way you're only focused on anatomy right now. All right. Stop recording.